Perfect. Okay, thanks. Hello to Cyberspace Division of Nephrology. Thanks for tuning in for Citywide Rounds. Today we have a guest speaker, and for those of you who don't know him, it's Dr. Gavril Hirsch, who's here to present actually in person at UHN, which is great, but you may know him mostly as a longtime nephrologist at Humber River. And he is an associate professor of medicine at University of Toronto. And he has a really interesting career path because he completed his, first I have to mention, he's graduated from McGill. So well, we have to brag every time we can. Secondly, he completed his psychoanalytic training actually at the Toronto Psychoanalytic Institute and is a member of the Canadian Psychoanalytic Society. And he's really a pioneer in the whole concept of psychonephrology. And he actually maintains a website and social media platform at psychonephrology.com. And his major area of interest is the impact of physical illness on patients, families, and caregivers. And he is able to practice both in renal care and also psychotherapy of patients coping with serious medical illness. And it's really a pleasure. I remember hearing his talks through my training, and even these have stuck with me. And so it's a real pleasure to have him here to talk about something we often deal with, but don't address properly, and very important for patient care and quality of life. So thank you.
Thank you for that, Heather. And I must admit, it was an interesting question whether to come in person or to have a Zoom session. And at the last minute, I thought it probably is more concordant in terms of coming in person, after all, given the topic, and in terms of human connection. I'll lay it out to you in terms of what I'm hoping to talk about today. And what I'm going to talk about today is really something that we face continuously around us. It's part of every human interaction, and it's not purely with patients. It's part of our interaction with our families, our spouses, our children. It's sort of interwoven into every aspect of our humanity. But in some ways, it's non-quantitative. It's very difficult to understand. It's very confusing. Your children come home and they're screaming, or your husband or your wife is in a bad mood. We don't really have a mechanism for understanding these things. So it becomes a very turbulent situation. Or you're in the clinic and some patient keeps complaining, doctor, why are you so late? And you're saying, I'm rushing. I don't know why this patient is giving me so much negative feedback. I hope I don't have to see him or her again, because this is not making me feel good about what I'm doing. So not only is it that we're having these interactions with sort of illogical situations, but it kind of leaves us feeling a little bit turmoiled inside, and we don't know what to do with it. So what I'm hoping to lay out for you is really a perspective of how to understand this better, because things will not change. You will not have logical interactions with patients on a continuous basis. Just the very definition of somebody being a patient and being ill and coping with illness means that they are going to be emotionally turbulent. And for sure, the kinds of patients that we see who are transitioning to different areas of their lives in terms of their renal course will face transitions and turbulence. And so it's part and parcel of what we do. But we don't have a good handle in terms of understanding it. And so we're left perplexed. And also, what I'm going to talk about is really what are the barriers to achieving that connection? What are the barriers within ourselves, within the hospital cultures that we work in, and also on a societal basis? So that's kind of the premise of what I'm talking about. I have to make sure I warn you that there will be probably very little numbers or quantitative material. So I just want to make sure that's going to be okay with everybody. The next provocative point I want to make is, you might say, well, it's great. We're in the clinic, people are having issues. We should get a psych consult. Is a psychiatry consult helpful nowadays? And this is why I say that the mental health model has a problem. Why? Because psychiatrists have become a subspecialty of internal medicine. I don't know if that's your experience or not, but basically, if you send somebody for a psych consult who's having anxiety, they will say generalized anxiety disorder. And the formula for you is 8 CBT treatments, and I'm going to start you on an SSRI, and come back in 3 months and let's see how your medications are doing. There's no psychotherapy. Like many of the psychiatrists who are in training are receiving very little psychotherapy training, actually. So basically, it's formulaic, it's become more pharmacological, and psychiatric illness has become a biological illness. The important point I want to make is that most of our patients do not have a psychiatric illness. They have an emotional turbulence, right? Any one of us in the face of major illness, dialysis, transplant, etc., will develop turbulent, distressed behavior. It's normal. It's part of the human condition. It's not a psychiatric condition. And so in a way, we are speaking, psychiatry is on a different wavelength from the majority of our patients. Our patients do not have schizophrenia, bipolar disorder, obsessive compulsive disorder. Our patients are coping with the ebbs and flows of daily life. And this is the point that I'm trying to really focus on, is that in a way, we're connecting with our colleagues who don't really appreciate what our patients are doing. So in their perspective, a symptom is a disease, right? So if you have anxiety, there's no exploration of why you have anxiety. It's more, you have anxiety, that's your diagnosis, and here's what the treatment you need. But the anxiety is really a symptom. It's as if in medicine you would say, oh, Mr. Smith, you're in the emergency room, your temperature is 40 degrees. Your diagnosis is fever, and you need Tylenol, and that's going to take care of it. Oh, we know that's ludicrous, because they could have urosepsis, they could have whatever, bacteremia. The symptom is not a diagnosis. In psychiatry, by and large, the symptom has become the diagnosis, driven by managed care with limited access to psychiatrists on a long-term basis, et cetera. It's been driven by financial considerations. So the problem is that we don't really get much support from our psychiatrists. And what they say is, in my perspective, your patient has this bizarre behavior. It doesn't fall within our algorithm. You're going to have to go across the street to see another clinician who kind of has a perspective on what you have. And that's the unfortunate thing, what happens. The other aspect of what happens is that in this model where the patient is there having bizarre behavior, we minimize our impact in terms of the patient connecting with us and what we can bring in terms of helping them just with the connection with us. We underestimate how powerful that connection is and how much our empathy can stabilize where the patients are at. Because we can't measure it. We can't measure empathy. So it's as if we don't have a way of communicating about it. This is just to show you, and again, this is from the days when we started the transition care, just to highlight how much, that, for example, this is looking at depression, how the patients can actually decline in their mental status to where they become clinically depressed. And in fact, these changes, these are quality of life measures, these changes are associated with increased mortality and morbidity. So it's not an innocent thing just to say your patient is in a state of disturbance. And I wonder, I don't have proof, I wonder to what extent, the high mortality that we see in patients who initiate dialysis, right? The highest mortality is the first 6 months starting dialysis, unexplained by all the parameters we can control for. To what extent is stress, depression, anxiety potentially contributing to that? I don't know. It's a provocative question. I'm trying to advance.
If it sticks.
Oh, maybe I can go here.
Exactly.
Okay. This is to highlight this is sort of patients appreciating the degree of social support they have, or to show you that when you appreciate that you have somebody in your corner, that you have support, you're less likely to be impacted emotionally. Having somebody there for you is the most important thing that can happen. So far, I've been talking about a problem, how we're not reaching our patients, and we don't have a perspective of how to make sense of this turbulence. What I'd like to kind of highlight for you is that I think viewing it as through the trauma perspective is very helpful in understanding what happens to our patients. So what happens with trauma? When you have trauma, so imagine like a tsunami, all of a sudden, tidal wave comes, or imagine you're going to a medical meeting in Japan and something happens to the plane and you have to land in North Korea and somehow you can't find your passport. And all of a sudden, the North Korean military puts you in a single room at the airport. Nobody speaks English and you're all alone and you have no idea if they're going to release you or not. Right? I'm just making that up. But these are traumatic experiences where all of a sudden your mind cannot contain the intense anxiety that you have, and it's as if the dam is breaking and everything is released. And so you are traumatized, and basically you begin to feel helpless. It's like, I'm alone here. I don't know what to do. I can't get out of here. There's a sense of hopelessness in it. And there's a loss of resiliency. When this happens, it's as if we lose the story of our life. Here's what happened yesterday. I bought groceries. Today I'm going to cook something. Tomorrow we'll have it for dinner. We have a certain cohesive narrative that colors our life. And that predictability creates a sense of resiliency. When you're traumatized, you lose that resiliency. You lose the story of your life, the continuity, and you live in an ever-present moment of anxieties. If you think about COVID, not that far away, all of a sudden we were like traumatized. Is the person that I'm close to potentially going to give me COVID? I have a little bit of a sore throat. Am I going to infect my family? Is the next patient I have to go see in the emergency room going to give me COVID? How can I reconcile wanting to help somebody, but also I want to keep my distance because I'm afraid? Do I stay on the sidewalk or do I get off the sidewalk when this person is coming towards me? Remember those curious negotiations when you're walking on the street? It was a very traumatic time and we were trapped. Like every day was the same. Everybody looked the same. We were isolated from each other. At a moment, it was a double whammy. It was a moment where we needed the support of each other, but it was potentially deadly to connect with another human being. And the most important impact of trauma is whether you have somebody with you or not. It's the impact of trauma is independent of the traumatic experience. You need to start dialysis. You have to get a transplant. You lose your transplant. It's independent of that. It's how much you feel that you have supportive family, physician, nurse beside you. The more you feel that you are with somebody and contained, the less impactful is the trauma. And in some ways, that's the most important thing that we can give to our patients. The important thing to keep in mind that these reactions are normal. This is not some medical illness, a medical disease. Being traumatized, reacting in a turbulent fashion is normal. All of us put in a situation, you get a call that your child was crossing the street from school and they were hit, they're okay, but now they're in the emergency room. All of a sudden we rush into the ER, we start screaming, where's my son? People are going, what's going on with this hysterical person? We're not dead. We are traumatized. Again, keep in mind when you become traumatized, the pot breaks. You break into pieces. And the manifestations are more defined, like besides anxiety, you can somatize All of a sudden, you're getting migraine attacks because the tension, the anxiety, the intense feelings that you are releasing need to go somewhere. And they either go into your emotional state, I'm feeling anxious, or they go into your body. And all of us have a connection between the anxiety areas in our mind and certain somatic areas from like age 2 months, 3 months. And it's a highway. So the minute you are stressed, it will go into your body and you have your unique area, somatic area that responds to anxiety. You get migraines, you get irritable bowel, you get hives, you get neck pain, you get back pain. All of us have areas where tension is released. Ideally, if you can talk about it, and that's why therapy works so well, you reduce the tension, you reduce the level of anxiety. And so when we see our patients, and it's not unusual to see them in the dialysis unit, in a transplant clinic, they may be having panic attacks, very severe anxiety levels. And then with time, hopefully with their own supports, their own resiliency, home supports, and our supports, they can migrate to an area where they can now begin to talk about it. They can begin to mourn those losses. And once you can mourn, you can move on. If you don't mourn, you stay in the present moment, as I talked about. And then the pieces come together, but it will never go back to being complete. Once it's broken, it's always broken. And as I said before, just by the very nature of being a human being, of living life, in a way, we are all broken inside. None of us really escapes it. This is what it means to be alive. So you would say, okay, fine, I agree with you. This is important. So what do you suggest? So I'm going to make a suggestion, and then I'm going to tell you what are all the barriers that we have to providing this suggestion. The most important thing you can do is containment. Now you could say, well, I don't know how to do it. I need a formula. If you have a spouse, if you have children, you're doing it without a manual. So when your child comes home at age 5, and they're like crying, I can't believe it, I fell down, or, nobody picked me for the soccer team. You don't go to your kid who's crying and say, listen, it's great that you're home. I hear what you're saying, but let's go do your math homework. It won't work. So you know that you need to provide some support, some emotional connection, containment, so that they come into a better place where now they're ready to learn and do something. You can communicate. Same thing if you have a 2-year-old and you drop them off in the daycare center and they're screaming for you. A 2-year-old who's screaming for his mother is sitting on the floor paralyzed. The minute that they feel contained, that they feel supported, they will begin to connect with other people, they will begin to crawling, and they can then begin to learn. When you're paralyzed with anxiety, you cannot learn. And that's the important caveat to that is that, and this is why transition care units are important, because when you start dialysis and you're anxious, there's no use bombarding the patient saying, here's the Kidney Foundation book on home dialysis, let us know tomorrow what you've chosen. Patients are so anxious that it's actually they can't retain the memory or the knowledge. And so you have to gauge on an ongoing basis, what is their progress? And then as you connect with them, as they feel more contained and less anxious, then education can begin. So the most important thing that we can do for our patients is to make them feel that we are there. Now, what does it mean to be there? Like I said, it's not formulaic. It's like thinking about being with them in a manner that you connect with where they are at, that you have an appreciation of what they're experiencing, with empathy. So, hurry up. The question is, great, so why don't we do that? There are so many barriers in the way, you're going to have to swim upstream for the rest of your life to do what I just talked about. So what are some of those barriers? Part of it is the barrier you have here in this hospital. not just this hospital, all the hospitals. What is the barrier? We have a biomedical model which says you have to do something. You have to diagnose some abnormality, and you have to provide a prescription and correct that abnormality. And the abnormalities are focused. The patient is really should be over there. You know what? The more quiet the patient is, probably the more efficient for the clinic, and it's better for everybody else. We don't need this cockamamie story about, you're waking up at night and you're anxious and you can't focus, and then your husband came home and he was upset. I mean, that's like noise. Well, I don't have time. I have 15 minutes in the clinic. Who has time for that? But if you don't make that connection, there's no use it doesn't matter how many prescriptions you give the patient, they'll never reach their pharmacy. The major motivation for healthcare is a connection with somebody. And in our system, we don't value it. So David Mendelsohn and I once did a study where we sent a questionnaire to nephrologists in Canada to say, do you think psychosocial care is important? Yes, I think it was 95%, 94%. And so what are you going to do? They said 97% said social workers should be doing it. Right? So basically, that we should have a specialist who basically takes on that responsibility. It's really not the doctors who do it. Right? We relegate it to somebody else. And so we live in a culture where we find all kinds of excuses not to do it. Well, if I listen to the patient, what happens if I open up this Pandora's box and then I have 15 minutes? Like, what's going to happen once I have to stop? I'm going to leave them there. Or, gee, if I listen to everybody's story, am I going to get empathy fatigue? I'm going to get burnt out. I can't. So in a way, we're finding ways to protect ourselves from some potential disaster that may befall us. I'll give you the counter argument. I think the more we create these barriers of engaging with a fellow human being, the more likely that we're going to get burnt out, not because we have empathy fatigue. We have our own personal barriers. We don't appreciate the fact that we connect with patients, that the patients are putting continuously hot potatoes inside of us, and it creates a turmoil inside of us. And we don't reflect on the impact that two-person interaction has, right? So we may say, gee, Mr. Smith, I'm really looking forward to seeing him. I always feel good. Or Mrs. Smith, every time she comes, I get angry, I get anxious, whatever. I hope she doesn't show up today. Every human interaction has this complex aspect to it because there's unconscious communication. The patients are continuously, especially the more vulnerable they are, and the more empathetic we are continuously handing us hot potatoes that we have to process. The less we reflect and acknowledge that we are involved in a subjective interaction, the more we think of it as a neutral, objective thing. You're bringing a problem, I'm solving it, what's the big deal? We deny our own humanity, and we are left holding all kinds of turbulent feelings, which are wearying, burnout, etc. The more we can acknowledge that, you know what, I'm in the middle. Every time I see a patient, I'm going to enter a storm to a greater or lesser extent. The more we acknowledge it, the more human we are and humane, and it's easier for us to process our issues. There's a whole stigma about physicians becoming emotionally ill. You're not supposed to talk about it. You're supposed to look after yourself, etc. So there's a whole stigma in terms of self-care, acknowledging that we are part of this very confusing situation. And as a result, we withdraw ourselves. And that's detrimental. These are patients that I follow in the clinic, just to give you an idea that the process we undergo when we provide care is a process of abstraction, which means all these patients who have the same serum creatinine, basically they all become rectangles to me because it's a serum creatinine with a blood pressure, but each patient is a very unique individual who was a child, who grew up, who had families, etc. Like they have unique stories which integrate with their biomedical abnormality. And you cannot split the two together. I mean, there's such a complex interaction between the mind and the body. It's not like, listen, leave your mind and your emotions at the door, just bring your body into the room. It's part and parcel of what we're dealing with. But what we're seeing are the rectangles. And in a way, what we're interacting with is the eye patients, right? It's like basically you are somebody with a biochemical abnormality, an X-ray, a fistula. And even if you're saying, okay, I'm doing rounds in the dialysis, there's a pale little lady who's kind of blocked up by the computers and these nice flashing dialysis machine. After all, it's so much more interesting to look at the readouts on the machine than this lady who was going to give me all kinds of confusing stories that in a way were increasingly distanced from the patients. And we even say, why do I need to see the patient? I can just sit here at the computer. I have all the labs. I can fax the prescriptions. I can be so much more efficient. Connecting with a human being, boy, that's like, it's going to take all day. What's that going to achieve? It doesn't provide any information. And to take it to the ultimate degree, there are office buildings in the United States filled with intensivists, ICU physicians, and ICU nurses, no patients. And what they're doing is they're looking after ICUs either in the same city, state, or several states over. Why? Because you can imagine if you're in a city of, let's say, 200,000, 500,000, you may or may not have an intensivist in the ICU, or that intensivist was called to the ER because there's a cardiac arrest, and there's no physician in the ICU. So these physicians and nurses are providing remote care for patients who are thousands of miles away. Very efficient. Now I'm going to talk about the last impediment, which is invisible. It's all around us. It's in your hands right now. The problem is there's this whole area of cyber psychology, how we have integrated our cell phones and other social media, the internet, into our everyday lives. These have become narcissistic extensions of ourselves. They have actually integrated themselves into our minds. We are continuously motivated to turn on our phones, and the frequency of turning on the phones on a daily basis is increasing. Imagine the anxiety if you go downstairs to get a coffee and you realize you've left your phone upstairs. Wow, I'm going to have to be with myself for 5-10 minutes. How can I bear that? How can I tolerate that? What am I going to do? It's humorous, but what it actually shows you is that we have actually become disengaged with our inner lives. We spend very little time on our inner lives, and we're spending increasingly more time processing information. We are becoming more concrete. We are becoming less self-reflective. And the frequency and the speed with which we answer texts and emails is increasing. And more of the time that we message is filled with excuses why we didn't reply fast enough to the email. I'm sorry I didn't reply to your email fast enough. Right? So we're spending more and more time spinning information, processing information. We're spending less and less time with each other. That's why it's so important that we're all together here. Forget everybody else out there, their loss. And we are becoming disconnected, not just from ourselves then, but from the patients because of what pervasively is happening around us. And the problem is that we don't have time to process the impact of what's happening because the algorithms and the software updates, the next 2-3 generations are already sitting in the library just waiting to be integrated. And there's a rapidity of evolution in terms of these systems. And these are having tremendous impacts on us. We have moved from a 3D world to 2D world. Actually, in the past, we used to have desire, I wish I could have this pair of pants. Gee, I wonder if I will like it. Gee, should I go? Okay, I'll go down to the store. I'll have a look at it. Desire. I want something. I'm interested. I'd like to date somebody. I'd like to marry somebody. There's a certain desire, fantasy. There's a delay where you have the fantasy, the imagination, and then delivery. Today, we've removed the delay. We've moved from desire to delivery. I want this, Amazon click, it's there the next day. The delay between what you want and what you get is what forms your personality and your psychology. The child who has space to be bored is creative because he doesn't stay bored forever. He says, okay, you know what? I'm going to start playing with this, or I'm going to do this. And in the process of that resolution to do something about their boredom, they begin to define themselves and say, oh, look, I'm able to do this. Now I feel better about myself. If on the other hand, you have parents that say, oh, I can't believe my kid is sort of sitting there doing nothing. We better get a play date going. We better give them a toy. Johnny, now start playing with this on the floor. The more we direct our kids to do something, the more resistant they are. They would rather play with the box that the toy came in because you're so busy telling them you have to play with it this way. We need that gap of doing nothing, of doing something inconsequential. You need that gap of a nurse in a dialysis unit sitting with a patient, doing nothing but listening. How often in your dialysis unit do you see a nurse who's there for 4 hours, looking after 3 patients, sitting there just listening to a patient? Right? I mean, everybody, I'm so busy, I have to chart, on the computer. 4 hours. Sometimes I would say 5 minutes, just spend 5 minutes with the patient. That's 15 minutes out of 4 hours. Yes, you're very busy when you put the patient on. Then you have like 2.5 hours of nothing. And then you're busy at the end when you take the patients off. Oh, I can't, I have so much to document. There's so many barriers to that because we're addicted. We need to go on the internet. We need to go on the phone. And so we've given up our control of our inner lives. If you look at the generation under 20s, oh, I don't know what to do. What do you say? I don't know. People have lost their gut feelings. So if you look at this generation in their 20s, many of them are sitting at home indecisive. They don't know what to do. They're sitting in the basement playing, all kinds of internet games because this is the fantasy is to be in a virtual world. The virtual world is an extension of yourself. There's a sense of, omnipotence, of power. There's no aging. You don't die. If you die in the game, you come back to life again. You continue playing. You live in a world where nothing changes. But then you've lost your soul. And so what's happening now in this generation, again, it's not like my generation was, but what you're seeing, I mean, I get referrals of a lot of kids in their 20s, intense anxiety because they're paralyzed. They are not going out to meet other people. They are not dating other people. They are reluctant to go into a relationship. We are, quote unquote, that's a new term. This generation is going into a sexual recession. People are not interacting. And more importantly, we're seeing the evolution of AI, which is breaking down further barriers. And it's sort of interaction with AI is basically replacing all kinds of intimacies. And I'm going to talk about AI therapy bots, which is now becoming more prevalent. And in a way, we are becoming more mechanized and AI is becoming more humanized. And we're reaching out more and more to AI. Therapy bots, it's great. It's 24/7. It's there for you whenever you need it. You're stressed, go on an AI therapy bot. And the pseudo empathy is becoming more and more refined. And now, increasingly, they can actually start monitoring pupillary dilation, In the near future, heart rates will be monitored. So when you connect with an AI therapy bot, they will kind of monitor different parts of you and say, oh, it looks like you're distressed. Mary, it's nice to see you again. We haven't spoken in a while. Please tell me what's on your mind. There's a pseudo empathy, but it's impossible to connect with an AI bot. But people are connecting with it, and some of the points I want to raise here is that there are some serious consequences where so sometimes they will say, oh, I'm really feeling very anxious. Do you know where I can find the bridge that's high enough? The AI is programmed to provide answers. That's the algorithm. And so it will say, oh, I'm sorry to hear you're anxious. Yes, on the Danforth, there's a bridge and the Bloor Viaduct is actually quite high. And people have actually committed suicide. They've been like, we're talking about children, adolescents, and adults. There are quite a few lawsuits now going on because the AI bot failed to recognize the consequences, and people have actually committed suicide. So we're kind of in a very curious, disconnected world where we are increasingly connected to these AI disembodied minds, which are really not able to truly connect with us. They cannot be empathetic. But we are relying more and more on these things. And just to show you an interesting study, there are actual online questionnaires where people can put in a question like, my son fell down, has pain in the knee, what should I do? And physicians actually answer the questions. So maybe take him to the ER, whatever. So they took these online questionnaires where physicians answered the questions, and they gave the same questions to AI engines. And then they clinicians compared the answers, and in all of them, the AI responses were deemed to be more empathetic and more connected than what the physicians put. The physician probably would, listen, instead of, maybe you should take your son to the ER. The AI answer was, oh, I'm sorry to hear that this happened. This must be very distressing for you that your son is feeling this. Yes, I really think it would be advisable. And, maybe let them know. Like it gives a lengthier answer, and seemingly it was more empathetic. And this was scored by physicians who said, yes, the AI provided more empathy. We're going down this road. So in the interest of time, I won't belabor the fact. We need some examples of, given what I talked about, what are some areas where we can create some change, where we can apply this? I think one of the important areas are, let's say, transition units, because transitions by definition are traumatic. Imagine a patient who's on dialysis, let's say at Humber, and they get a call that they have a transplant. In essence, what we're telling the patient is, oh, isn't it great you're getting a transplant? And you'll be going at Toronto General, they'll be looking after you. It's as if we tell our child, listen, mommy and daddy love you a lot. We've looked after you for the last 6 or 8 years, but there's this new family that's going to look after you from now on. And so and they're going to love you just as much as we did. And starting tomorrow, they're going to look after you. Goodbye. I'm providing this ludicrous example because it paints the picture of what it feels like for a patient who's been supported on dialysis for 10 years at Humber. They know the physicians, they know the nurses, and one day to the next, strangers are looking after them. Very traumatic. Or somebody who's on dialysis at Sick Kids and say, oh, you're 18, now you're at Toronto General. Whole new family is going to look after you. So being cognizant of that is very important in terms of the care we provide and with the transition. So I won't belabor that. Other areas, for example, they did a study on patients who were acutely, gravely ill. They ended up in the ICU. And you can see the patients, when they appreciated more empathy, more support in the emergency room where they first came in, when they were discharged from the ICU weeks to months later, noted decreased PTSD. So the idea being is just that containment in the emergency room for a short period when they came in, heart attack, sepsis, whatever, translated months later to lower levels of PTSD, major anxiety. So you can have a huge impact on the connection you have with somebody in the emergency room. And you're talking about, hi, how are you, Mr. Smith? We're going to help you. Don't worry, we'll be here. Versus, can't you see how busy we are? Wait your turn. Same amount of time, but a completely different language of communication. There's somebody very interesting at Stanford, Verghese. I don't know if you know the book Covenant of Water being made into a movie, Cutting for Stone. Very interesting guy. He graduated from medical school in Ethiopia, and now is like the vice chair of theory and practice of medicine. He's an internist, but they're looking at how to provide empathetic care. So they did literature review. They've actually sat with policemen, firemen to look at how do you provide support and connection for individuals. And they sat with physicians, and so they kind of reduced it to a kind of a digestible model of care. So what are the components of providing empathetic care, which is impactful? One is thinking about the patient you're going to see rather than here's another patient with a creatinine, and listening uninterrupted. The average wait time that you listen to a patient, all of us, 11 seconds. We cannot sit on our hands for more than 11 seconds before we interrupt the patient. The average time for a patient to talk uninterrupted is 92 seconds. So it's not like if I don't interrupt this patient, we're going to be here for hours. It's not. It's 92 seconds, and the patients will feel like, wow, this person really listened to me. They did a study with surgeons. They stood at the head of the bed for 2 minutes, or they sat beside the patient for 2 minutes. When they were standing, the patient's response was, I can't believe this guy, in and out, doesn't talk to me. Same amount of time sitting with the patient on a chair, same level. Wow, what a caring physician. He sat with me, explained everything, so much empathy. It's about quality of the connection, not the quantity. How mindful we are, and the more mindful we are, the more the patients will feel it. And that's what they're looking for, is that connection. And connecting with the patient's stories, so I won't sort of belabor this. Final messages. Important to keep in mind that we are focused on the left on the broken part. What is broken? What needs fixing? The patients, yes, they're concerned about that, but they're also concerned about the internal emotional voyage of their illness. It's not that we have to say now, okay, you know what, I'm going to focus on the illness. The important thing is, yes, I'm focusing on the disease, but just if I keep in my mind that there's an emotional journey, just keeping that in mind, and that you have that in mind, the patients can then borrow your containment, your appreciation of that topic, and use it for themselves. Just like when you have an infant who's screaming it because they're going to bed, with time, the fact that you're providing empathetic support, they can internalize that support and they can soothe themselves. And that's why with time, an infant can go to bed alone, because they have you inside their mind soothing themselves. So I don't think I'll spend time on the caveat because I think I spoke about that. I'm going to do a plug for psychonephrology. It's a website. The important thing is weekly blogs. So if you go to the bottom of the website, subscribe. Once a week, you'll get a push. There are actually video interviews with like transplant donors, people with PKD, people on dialysis. There are several we did with altruistic donors in the UK and the States. The whole website can be translated to any language of your choosing, which is very helpful for our patients who speak different languages. So you choose a language and the whole website is translated. There's a brochure I wrote about coping with anxiety and worry, CBT. We're on TikTok, Instagram, everything. And that's the end of my talk. So I'm happy to answer questions.